Can you hear me?
Yes, please.
Okay. This is Dr. Ababa talking, the moderator. Okay, I think it's time to start. Good afternoon. Good afternoon, all the participants, and welcome to this webinar. Today, our guest speaker is Dr. Simon Skalski. He is a consultant ophthalmologist and a glaucoma specialist. He is an associate professor of ophthalmology of the University of Melbourne and Royal Victory Eye and Ear Hospital in Australia. Dr. Skalski is an immediate past president and current active executive member of the Australian and New Zealand Glaucoma Society, and he's also a member of the editorial board of the Society Journal. Dr. Skalski is an active member of the World Glaucoma Association as well. In 2050, he wrote an authoritative textbook on ocular and visual physiology that's adopted as a core textbook by the Royal Australian and New Zealand College of Ophthalmology. Dr. Skalski has over 60 research that are published in reputable international journals. His research and being a skilled computer programmer led him to the development of an online visual field testing through personal devices. In 2019, he found Eyeonic technology supported by Microsoft to provide all assisted online visual field testing on any computer or tablets. I hope he will brief us on this new technology. So with this brief introduction, I would like to invite Dr. Skalski to start his talk, and to all the participants, if you have any questions or comments, please write on the chat box, and Dr. Skalski will address at the end of this presentation. Thank you.
Thank you, Dr. Abeba. It is a real pleasure to be here and speak to you all. I already have a lot of friends in Ethiopia from our previous work, and it's great to meet you all. And it's also my pleasure to introduce David Kwati here, who is our commercial executive for Africa and the Middle East. I really hope that you enjoy this talk, and I hope that you don't just enjoy this talk, but you take interest in this technology and start using it. And I really hope that it helps you in your practices and will be useful. So I'm going to begin my presentation, and as Dr. Abeba said, if you have any questions, please put them in the chat. I'm going to share my screen and turn off my video because I think that it'll be a bit smoother with the video off, but you'll still hear me. So what I'll be talking today about is the interpretation of visual field testing and the Eyeonic online visual field test that I've had the privilege and pleasure of being involved in. These are my declarations. As was said before, I'm the director of Eyeonic, which owns the patent regarding this revolutionary form of AI-based online visual field testing. So a lot of us know what visual field testing is, but I think it's worthwhile talking about it in broad terms. So the visual field is a measure of the loss of peripheral vision. And to be very simple about it, we ask the user to look at a target right in front of them with one eye at a time, and we shine lights in their peripheral vision and see if they respond to it. And it generates a map of how well they can see at every position in their peripheral vision. And it's used to measure loss of peripheral vision. And as you can see here, this person has done a visual field test and they're missing vision in the top half of their right eye. That's what we can see here. And what the visual field does is it evaluates the contrast threshold at each location. So in the central locations, the person is seeing well at 26 decibels, but at these far spots, that person is not seeing anything, so he gets a score of 0, while at some of these other spots, they're seeing something, but not so well. So that's why the scores are 7 and 14 and 17, but less than the 26. And the sensitivity at each spot is measured in decibels. And I'll go through soon what all of these extra numbers mean as a good rejig of the memory of how to interpret these. Why do we do visual field testing? Well, we do it related to glaucoma and optic nerve disease. And I know that glaucoma is a very common condition throughout the world, and it affects people in Ethiopia, it affects people in Australia, all over the world. And it's something we all have to be mindful of. So anyone we see with suspicious disc cupping, like in this case, or if anyone has raised pressure in the eye, or if anyone has a family history of glaucoma, these are the sorts of people that we want to screen for glaucoma by doing visual field testing. And it's not always apparent just from looking at the optic nerve, and sometimes the visual field test helps us decide if it's glaucoma or not. And if they have optic nerve disease from other conditions, such as non-glaucoma affecting the optic nerve, such as a toxic optic neuropathy or an ischemic optic neuropathy, a visual field test is very useful. And also if we suspect brain disease, if we suspect someone might have a tumor in the head, or if they've got potentially had a stroke affecting the visual pathways or raised intracranial pressure. By the way, I'm sure a lot of you would have seen that this person in this disc photo has got a Drance hemorrhage, an optic nerve hemorrhage. So this is very suspicious for glaucoma. So what conditions can cause visual field changes? Well, we've talked about glaucoma, and we've talked about other optic nerve diseases that are not glaucoma that can affect the optic nerve, but also brain tumors. So both brain tumors that can affect the visual pathway, say in the occipital cortex, but we all know that pituitary tumors that can affect the optic chiasm can affect the visual field and cause a bitemporal hemianopia. But there are other sorts of tumors, such as gliomas of the optic nerve, that we need to be considerate of. And as I mentioned, cerebral vascular disease affecting the visual pathways or inflammatory disease affecting the visual pathways can cause visual field defects. So any neurological case or anyone with unexplained headache, unusual optic nerves, these are the sorts of people we should be doing visual field tests. Retinal disease can also affect visual fields, not just central retinal disease like maculopathy, but peripheral retinal disease. So someone that has had PRP laser, for instance, for diabetic retinopathy, or has had a retinal detachment previously, these will affect the visual field and cause visual field changes, and as will an inherited retinopathy like retinitis pigmentosa. And some medicines such as hydroxychloroquine can affect the visual field, and that's why a lot of my patients that I see have rheumatoid arthritis and they're on hydroxychloroquine for that, and I need to do regular visual field testing to ensure that they're not getting maculopathy from the hydroxychloroquine. Different diseases can affect the visual field in different ways, and this is a good slide, and I'm happy to share it with you all to think about the different types of visual field defects, starting with a central scotoma, which, as you can see here, it's affecting the central vision. So it's not typical for glaucoma, but it can affect, can be due to macular disease, such as age-related macular degeneration, optic neuritis. If you look at this case here, number 2, you can see that they've got a very large blind spot, so large that it goes to the center. So that's called a centrocecal scotoma, a central scotoma that involves the blind spot. And that's characteristic of optic nerve disease, such as optic neuritis. You can see here, this is a ring scotoma, so it tends to affect the peripheral vision. This dot over here, by the way, is the blind spot, so that's normal, but all of this is abnormal. And the ring scotoma is pretty classic of an inherited retinopathy like retinitis pigmentosa, but sometimes drug toxicities like vigabatrin. If you see here this number 4, this is what we call a nasal step. And in fact, 4, 5, and 6, they're all defects that respect the horizontal midline. And so these look a lot like glaucoma now. So you can see number 4 here, this is this relatively small nasal step. That's a retinal nerve fiber defect. That's characteristic of glaucoma. And those of us that are glaucoma specialists, we see this all the time. And this, if left untreated, will turn into this, which is a much larger arcuate scotoma that's starting to affect the midline, but you can see the arc forming like so. And that's what we call an arcuate scotoma. And then for even more disease, you can get an entire wipeout of a hemifield. So this is an altitudinal loss. You can get this in advanced glaucoma, but you can also get it in anterior ischemic optic neuropathy or a branch retinal artery or vein occlusion. What's interesting here is this person also has a tiny nasal step inferiorly. So you have to wonder, is this glaucoma where they've got lots of disease at the top and just the beginning at the bottom? So 4, 5, and 6 represent diseases that obey the horizontal midline, but 7, 8, and 9 are obeying the vertical midline. So you can see a lot of vertical lines here. So number 7 is this fairly classic bitemporal hemianopia, which is classic for an optic chiasm defect like a pituitary tumor. Number 8, you can see that this is a homonymous hemianopia. So whether it's the left eye or the right side is affected. So we know that this is a disease process that is beyond the optic chiasm. So that is either the optic radiation or the occipital lobe, such as in a posterior cerebral artery occlusion. And finally, we do sometimes see a homonymous quadrantinoepia. This is a superior quadrantinoepia, but you can get inferior quadrantinoepias. And a superior quadrantinoepia more locates to the temporal lobe, while inferior more the parietal lobe. And congruency refers to how similar they are. So we can learn a lot from the visual field. As I said before, I'll talk through how to interpret these. I know a lot of you know this already, but I'm happy to talk through it. The first thing, the most important thing is, do we have the right person and the right side? So the name normally goes here, but to protect this person's privacy, I've whited out the name, but you will see the name there. It was their right eye. The test was done on the 2nd of November in 2023, and the test took 4 minutes, 29 seconds. These data up here are about reliability. So the visual field test is a subjective test, and it's as good and bad as the concentration of the person doing the test. And that is part of the weakness of the test, but it's also a strength of the test. We're asking people, what can you see? And so there are human factors there. And these reliability criteria pick this up. And there are 3 important criteria: fixation loss, false positive, false negative. Now our Eyeonic system tests for these in exactly the same way as the machines do. Fixation losses by seeing if people respond to dots in their blind spot, false positive when they click when they're not supposed to click, and false negative when they don't click when we already know what they can see at that spot. So we check for all those things, and this person has a fairly low rate, so this is a reliable test. We also create global indices, a visual index, which is like the visual field index, the mean deviation, and the pattern standard deviation. And all of these 3 are really important. The visual index is probably the most important. It's a percentage of what the person can see. So when my patients are asking me, how much vision have I lost? How much can I see? I would say to this patient, well, in your right eye, you've still got 63%, but you've lost 37%. So that's a good way for people to understand what's going on. The mean deviation is a summary of all of this, of the total deviation, which is an age-matched score. and the more negative it is, the worse their vision is. While the pattern standard deviation is a summary of this, the pattern deviation. And what that looks for is not just the global change, but looking at focal change, looking to see if there's been any individual foci that are consistent with glaucoma. And as you can see here, this person is not seeing well at the top, but they're seeing well at the bottom. So the pattern standard deviation is relatively high. If they had a complete wipeout of their field, if they weren't seeing anything, then you'd have a low pattern standard deviation around 0, but you'd have a very poor mean deviation. And then there's also this test outcome, which looks at the test results and tells you if it's normal or if it's outside normal limits. And a lot of people who are untrained with visual field testing, say patients, they say, well, is it normal or is it abnormal? And we tell them to look at this line because that's what's so important. When we do visual field testing, as I said before, we create a map of sensitivities at every point. In the 24-2, we're looking at 52 points, going from 3 degrees to 24 degrees. And these are the raw sensitivity values. The higher the sensitivity, the better they see. And then below is sort of like a gestalt, an impression of that. And you can see here, they're missing a lot on the top, but they see pretty well on the bottom. But once we develop this map of the sensitivity values, the question is, well, is this normal or is this abnormal? And that's when we go to the total deviation, which looks at these sensitivity values and compares it to an age-matched database. Now, for this person at this age, 26 is what we would expect, 26 decibels. So that's why all of these 4 points are getting 0, because they're 26, 26, 26, 26. While this point here got 25, so it's -1. And this point here got 0, so it's -26. And then you might say, well, that's all well and good, or clearly this one is 2 less than we expected, this one is 5 less than we expected. But is that difference significant, or is that just a random fluctuation? And that's what this map helps us with. So you can see here that this point is -2. It did not reach significance, and the significance is provided by these colors here. This point here that got to -4, it did reach significance, but only the lowest level of significance at less than 5%. While these points up here are all really significantly abnormal, and that's why they're the darkest color at less than 0.5%. And then the difference between total deviation and pattern deviation, in some people, they have a diffuse loss, such as from cataract or refractive error or a media opacity, and that can affect all spots of the total deviation. And we're not so interested in that, in glaucoma in particular. We want to know, is there a focal loss? So moving from total deviation to pattern deviation is a chance to look for focal loss. Now, in this case, there was no difference between total and pattern deviation, but I'll show you some other examples where there was. A lot of people are interested in change over time analysis, and that's something that our Eyeonic system does well. You can see here that this is a progression analysis of one person of their left eye, and we have both a trend and event analysis. So I'll walk you through that. Firstly, the trend analysis is here, and you can see that each of these blue dots represents a test. And you can see this person did 3 tests at roughly the age of 65, then another one at roughly the age of 66, and then another one at age 67. So we've been monitoring him for about 18 months or so. And what you can see is we've plotted his visual index. And initially they were pretty good at around the 61. Well, not pretty good, but pretty stable. But then he started getting worse and got all the way to 41%. So this trend analysis shows us that there has been a change over time, and that change is around -12% per year. And it gives us a significance. So that's quite a significant and a large drop. So that's something to be concerned about for this patient. He's getting worse. But we also have an event-based analysis, which looks at point by point. And I'll talk you through how that works as well. So the way to do that is we have 2 baseline tests, his first 2 tests. One was done in November 22, and the other one was done in January 23. And you can see they're roughly similar. This one's got a visual index of 62%, and this one is 63%. But the most recent test has a visual index of 44%, and you can see it's a little bit worse. You can see that there's more spots affected than these initial few tests. But it's this analysis here that's so important. And you can see that if there has been a significant change, is it only on one test, two tests, or three tests? That's what these colors show. So the light blue shows it's only gotten worse in the last test, but the most dark blues show that actually over the last three tests that's gotten worse. And the black square means that he was so poor in those spots that he's reached the floor, so there's no way of seeing if it's gotten worse. So this is clearly someone who's getting worse, both on the event and the trend chart, and progression has been detected. A lot of people want to know if there's a few spots missing here and there, is that a real visual field defect? Because we all have patients that do visual fields, you know, a few spots missing here and there, is that significant or is it not? And the answer is these, what's called the Anderson criteria, where if you do have a defect, which you can see here, it's 3 or more non-edge points. So you can see here, while some of them are edge points, we've got at least 4 that are non-edge points, and they all need to be at less than 5% with at least one less than 1%. So what that means is at least one point has to be that darkness or that darkness. And you can see there's 2 like that, as well as those 2 edge points. So this actually is a significant scotoma. And this is a good example of how the total deviation, it maybe wasn't so bad, but once we moved to the pattern deviation, we were able to bring out the defect. So that's the importance of moving from total to pattern deviation. And we also, if we can't find a significant scotoma, then we also look at the test outcome, and here you can see it says outside normal limits. So that's how we know that even though this person, they've got a very good visual index of 98%, they actually have early glaucoma. Now, there are different types of protocols for visual field testing, and I'll talk through all of them. So the first one, the most common, is the 24-2, which I've been showing you. And this is the one I recommend you use for 90% of the time, because it tells you everything you really need to know. It goes out to 24 degrees, which is what the standard machines do. And you can see here, this is someone who's got some predominantly inferior field defect and a little bit of superior. In some cases, you want to look at the very center of their visual field, and that's when you use the 10-2 visual field test. So you can see here an example of someone that, this is one of my patients, where we did 10-2 perimetry and we found a few spots affected in the center. So out of interest, we again did it on the 10-2, and you can see when you magnify the central bit to here, this point here has become this defect there, while this point there has become this defect there. So what it is, it's a sort of more granular, more magnified view of what's going on in the center. We use 10-2 perimetry either when we're interested in macular disease, or when we have someone with such advanced glaucoma that it's starting to affect fixation. And in that case, we're more interested in what's happening in the very central 10 degrees. So a lot of my more severe patients, as they get worse, I move over from 24 to 10-2 perimetry. Going the other way is the 30-2, which is the wide field. And you can see an example of here. This is someone that's had 24-2 perimetry. And then we did 30-2 perimetry, and you can see the 30-, it just goes a little bit further out. So while the 24 stops at 24 degrees, that's there and there, the 30 goes a little bit further, all the way to 30 degrees, and you can see further to the side of the blind spot. And this is a good case of someone who does have a few spots missing really far out, but that wasn't picked up on 24-2 perimetry. In some neurological cases, some neurologists prefer 30-2 to 24-2, but I must confess most neurologists I speak to are happy using 24-2, so we're using it less and less, the 30-2. Two other very important tests that are really useful are the license testing. So as you know, visual field testing is not just used for clinical diagnosis, excuse me, it's also used for license protocols. And in most parts of the world, to get a driver's license and to maintain it, you have to pass certain visual criteria. Now, our Eyeonic system copies or does the same thing as what the machines do, and it goes 120 degrees in horizontal span. So you can see here, this is a driving binocular test where the person did it with both eyes open using our system, going all the way from 60 degrees to the left to 60 degrees to the right. That's 120 degrees of span and 40 degrees vertical span. So this is enough for a driving license test, but the difference is you don't need to do it on a large machine. You can now do it on our Eyeonic application. And as you can see, it also shows false positive rates, false negative rates. This person missed the spot down in the very corner here, but we're able to see everything else. We also have a pilot test, which is similar to the driving test, except it's one eye at a time, because when we test pilots, we want to know what's happening one eye at a time. It goes from -50 to 50 degrees, but otherwise it's very similar to the driving test. And this is also very useful for pilots, particularly, all pilots need to be assessed for their vision, including a visual field test. So this is both the pilot and the driving are super threshold tests. They're licensing tests, and they can be used to see if someone deserves to have a license. Now, I want to talk a little bit about glaucoma, because glaucoma is such an important condition and such an important reason why we use visual field testing. Glaucoma is a progressive and irreversible optic nerve disease that's related to usually high pressure. I think everyone knows that, but it's important to say it. And you can see here, this person, they've got a normal optic nerve head, except when we reach here where it thins out. And I hope you can see that there's a wedge defect missing. The RNFL is darker there. So this is a focal glaucomatous defect, and it affects the inferior nerve, causing a superior defect. While this person has got more diffuse thinning of the optic nerve, you can see they're cupped out everywhere, and that's caused superior and inferior visual field changes. We know that the prevalence of glaucoma is rising globally, especially in Africa and Asia. That is where the greatest burden of glaucoma is going to happen between now and the year 2040. And we need to make sure that we have the resources to address our patients. Sadly, most cases of glaucoma are undetected around the world. And if there's anything that motivates me, this is it. Because we know that for every undetected case of glaucoma, these people are silently losing vision. We know that if we waited for glaucoma to cause symptoms, we'd be waiting far too late. And we know that we could pick up glaucoma much earlier if we could detect it earlier and therefore save sight. In my part of the world, 59% of cases are undetected, and I get upset about that. But that number goes greater when you go to every other part of the world. And sadly, the number reaches 94% in Africa. So there's a big unmet need for earlier and better diagnostic tools in glaucoma. And that's where I hope the online visual field test will prove to be so useful. We know that glaucoma is a slow journey, starting from normal to advanced blindness. And we also know that early detection saves sight. And what we have on our side is that it's a relatively slow journey. So there's plenty of opportunities to pick up glaucoma early on and intervene to lower the pressure to preserve vision. Now, talking about current perimetry, current visual field testing, I and probably a lot of you are used to these large machines for doing the testing. Now, the machines, they work, but they are expensive and big. And expensive in terms of money and time. They are labor intensive. Patients don't enjoy them. They cause claustrophobia and they're stressful. They are in the clinic, so you have to access them by going to the clinic, which can be hard, particularly for people in rural and remote regions. And they have a very large footprint. They take up a lot of space. They need a dedicated, quiet, dark room, which is not always practical. And really, you might have a few in some of the more sort of academic, larger centres, but once you move out of those centres, they're few and far between. And when people lack access to perimetry services, sadly, that means people are detected much later for their glaucoma. In comparison, we have machine-independent perimetry, such as our system, which can be on any computer or tablet. It's cheap, accessible, it's so easy to use, it's very patient-friendly, and it can be used any place, anywhere. And that's the advantage of online perimetry. So I really encourage you to check out our online visual field system. It's so easy to do. Just go to www.eyeonic.com and you get a free trial. You do have to enter some details and then you can have a free month. And please contact David for further information of how we can organize that for you. It's visual field testing on any computer or tablet, could be done in clinic or at home. And it's all about the usability, the accessibility, and the affordability. And what began as me in my clinic in Australia, we've now really created a global movement where we've got data from all over the world, which I'll show you. Vietnam, Uganda, many parts of Africa are now using it and enjoying it. There are lots of advantages of online visual field testing. For me, what was so important is the more enjoyable experience. And what started me on this process was because I saw, I'm a busy glaucoma specialist and a lot of my patients are doing visual field testing, and I saw how unhappy they were doing it, and they all complained about the visual field machines. And I thought, well, is there something I can do to make it better and make it a more enjoyable experience, a bit more like a computer game? And that's what we've done. And then I realized that it's not just about the more enjoyable experience. Being an online application means that healthcare access is so easy, it's ubiquitous, people can do it anywhere, and it breaks down the traditional barriers of healthcare. It allows at-home monitoring. The patient is in control of their own data, although they're only doing tests that you, the clinician, sets. So the beauty of the system is patients can't just log in and do tests whenever they like. You, the clinician, set the test, whether you do it in your clinic or get the patient to do it at their home. You're in control. It integrates really smoothly with other clinical systems such as electronic medical records. It's great for improving clinic flow. We all know what it's like to be in a busy clinic where we've got lots of patients waiting and maybe the visual field breaks down, or maybe someone's having trouble on the visual field and that causes the whole clinic to slow down. But doing it this way allows a lot of improved clinic flow, and there's a significant cost saving. This system is way, way more cost efficient and way, way more economical than the conventional machines, which are large, expensive, and frequently break down. We've done a lot of research work looking at this and comparing it to the conventional machine. We also have done some work comparing it to itself on different computers. And this is one of my patients doing it on 3 different computers. He has glaucoma, and to see how it correlates. And you can see we've got a cohort of 61 patients that have done it on 3 computers, and the correlation is really strong. So the point is that it doesn't matter what computer or tablet you do it on, the test works well. And this is how we've achieved this technology, as I said before, working with Microsoft. The fixation target, which is what the person looks at, is this spinning gold star. And that's important because as it spins, it's an easy target to look at. People won't want to look away. One of the causes of stress during visual field testing is people feel like they're trapped in the machine and they don't know how much longer they have to go. Well, what we've done is we've got a progress bar like this, which shows you how much you've done and how much there is to go. A bit like when you download something. And that provides reassurance and that makes it less stressful. We've carefully chosen our parameters so that it'll work on any computer. One of the tricks that we've used is we have a very pale background. You're probably aware that on the conventional visual field machines, they have a dark background and they have tiny white lights. But what we use is a very bright background, this pale gray, so that the computer is the brightest light in the room. And then the targets are these flickering contrast targets, which are designed to flicker at the correct rate and the correct size so that they're relatively resistant to the differences between computers. We know that computers come in different shapes and sizes, and the app measures how big the computer is and then tells the user where to sit. So in general, the smaller the computer, the closer they sit, and that's how they maintain a constant viewing angle. As you can see here, the smaller computer is closer than the larger computer. The star can move, so the star typically moves across all 4 quadrants, and as the star moves, we're able to sample more spots. So in moving the star, you see in this example, when the star's at the top, we test the bottom half, and when the star moves to the bottom, we test the top half, and that allows us to take full use of the entire screen, and that's how we can get all the way out to 60 degrees for the license testing. Now, one question that a lot of people ask is, how do you make sure that the person's sitting at the right position? Maybe they're sitting too far back or too close. And the answer is, we find the user's blind spot. So first, the app tells them where to sit based on how big the screen is, say 40 centimeters or 50 centimeters. But then one of the first steps is to find the blind spot, which is normally to the side of the star. If the blind spot is found too far to the side, then we know they're sitting too far away from the screen, and the test will pause and will say, move closer to the screen. And that will keep going until they're in the right position. So finding the blind spot is very important to make sure they're in the right position. And once we have found the blind spot, we use that for fixation losses. But then the question is, well, how do you know once you found the blind spot, how do you know they're not going to move? Maybe they're going to move forward, back, left, right during the test. And the answer is, we use a webcam to monitor them. So this is where the artificial intelligence comes in. The computer's webcam monitors the face and makes sure the face doesn't move too much. And if it does move, then it pauses and it asks them to reposition accordingly. So in using these mechanisms, we can perform the test without a headband or a chin rest or anything like that, because we know that what's important is to do the test without additional hardware. We want people to be using their own computers, and we don't want them to have to buy any gadgets or any hardware to add to the computers, because that in itself is a barrier. We want it to be easy and straightforward to use. Now, the test uses an algorithm, a bit like the sitter algorithm, where it's around 2 to 3 minutes for normal and 5, sometimes 6 minutes for glaucoma cases. And there's a lot of screen calibration that happens. The test will ask the user to put the brightness up so that the screen is bright enough. But then based on the first clicks and the first responses, there's a lot of behind the scenes calibration that happens to make sure there's consistency despite differences in monitors.
Your
Here's an
test is about to
example.
begin. Please close your right eye and look at the star at all times. Press space or click the mouse when the target appears.
The first thing that's going to happen is finding the blind spot. So every time we see the target, we click and you hear that sound. Now it's trying to find the blind spot with these little ones to the side. And you can see here, we're not clicking, so we found the blind spot. Now,
Move a little closer to the screen.
what happened then is that the person had moved back from the screen and the AI had noticed it, and that's why the star went from yellow to blue, and the test said move a little closer to the screen, and it only continued once the user had moved to the correct position. So that's how we make sure that the person's sitting in the right position. A lot of people ask us, it sounds great, but what should I use? Should I use a large desktop computer? Should I use a laptop, or should I use a tablet? And we say whatever works for you. We want to make it as easy for you as possible. But if you're going to buy equipment, I would recommend the laptop here in the middle, because it's so easy to use. And one of the advantages of the laptop is you can tilt the screen. So you can see here, this screen's a little bit tilted back, and you can tilt the screen to make it easier on the neck of your patients. So I think that's really important. The other thing we recommend is people wear the glasses for reading, because you're often closer to the screen than you might think, and you need to have appropriate refraction for that. And it's important to make sure that the room it doesn't need to be completely dark, but mostly dark, and we want the brightest source of light in the room to be the computer monitor. And you also need to hear. As you heard in that demonstration, there's sounds, both spoken and some clicking sounds. So it's important to have the speakers on. Here's an example from Uganda of someone doing the test. A lot of people ask, well, how does your test compare to the standard? Is it as accurate as the machines? And I would say yes, we've done a lot of research, not just in Australia in my clinic, but all across the world. And all the data points to the same thing, that there's a level of accuracy consistent with the machines. Here are some examples of our test compared to the standard, where you can see that both have normal here. This person has some early glaucoma, with the nasal step on both sides. And this is someone with more glaucoma with a superior nasal step and a larger inferior defect. Both the Eyeonic and the standard test show the same thing. And then you might say, well, that's just 3 cases. Are you just picking 3 cases? What about all cases? And the answer is, well, we did one study that was published last year looking at 225 cases of mixed normal and glaucoma. And what we looked at was the sensitivity and the specificity combined to form the area under the curve. So that's a good measure of the accuracy of a diagnostic test. And what you can see is that in the cohort of 225, our system was very similar to the optic nerve OCT, the standard visual field, and the macular ganglion cell OCT. But and there was no significant difference between all. All was around 0.85 to 0.9. But the difference is all of these other things were large, bulky, expensive machines, while ours was an application that will work on any computer or tablet. And we've published now 5 papers, and we've got another 6 in the press. I've talked before about the user experience, which is something that I care a lot about to give my patients a better experience. And it's not just what I think. We did a study looking at 100 patients who did both our Eyeonic test and the standard machines. And then we used a 10-item questionnaire to survey their experience. And we found that 8 of the 10 items were significantly positive towards Eyeonic. So there was a clear preference towards the Eyeonic system. And when we asked them one question, which do you prefer? 84% preferred the Eyeonic to standard perimetry. So that was a very strong endorsement of our system. One question that people ask is, well, what's the repeatability? Is it fairly stable over time? And the answer is yes. You can see here this example of someone who's had the test repeated and there's no significant change. And we published this in the Journal of Glaucoma a few months ago. We've long believed that our test would be useful for Africa. Hardware for perimetry, the big machines, they are expensive, they are difficult to service, while computers, tablets, and internet are much more common in Africa. And so the accessibility and the affordability of visual field testing is improved, leading to cheaper and easier glaucoma monitoring, earlier diagnosis and sight saved, and more affordable healthcare delivery for you and for your patients. Here's an important study by Dr. Olawoye, who we are now collaborating closely with in Nigeria, and she's spearheading an Eyeonic pilot study in Nigeria. But before she did that, she published this study looking at the clinical characteristics and stage of glaucoma in sub-Saharan Africa. And this was over many centers, a very large study. And what they found was that 58% presented with severe glaucoma. And I can tell you that's a lot more than in my clinic in Australia, where only a small proportion present with severe glaucoma. So what this study shows is that glaucoma patients in Africa are presenting late in their disease course. And linked to that is the majority of patients did not perform perimetry. And why did they not perform perimetry? Well, some of them just couldn't see well enough to do it. There was a lack of appropriate devices. They didn't have the machines around, and they just didn't want to do the test. And I think you can understand, because a lot of people find this sort of machine uncomfortable and unpleasant to use. So that's why we really feel that there's a role for the Eyeonic system in Africa, and hopefully you'll agree that there's a role for it in Ethiopia, where already we've had a lot of success. But first, let's talk about Uganda, where we've probably gone the furthest in terms of validation studies, working with my good friend Simon Arunga here, and also his student, Dr. Honore Nizeyimana, who just successfully completed her master's thesis on this. This was a study out of the Mubara University where we recruited 184 patients, normal and glaucoma, pretty much any patient that walked through the door, and they completed the Eyeonic online system and also the standard machine visual field test. And it wasn't easy to get access to the standard visual field machine. In fact, the one that we started doing, the room caught fire, and then we had to go to the private, Dr. Arunga's private, to complete the work. But I'm glad we completed the work, because you can see when we looked at mean deviation, pattern standard deviation, visual index, we had great sensitivity, great specificity, great area under the curve. In other words, a lot of agreement between our test and the standard machine. But the difference was ours was so much cheaper, more accessible, and much more enjoyable for the patients. So after this study, Dr. Arunga has been very supportive of Eyeonic. He wants to help us get the message out. He's invited me to speak at his journal, the Journal of COEXA, Southeast African Society. He invited us to be a sponsor at the COEXA meeting in Zimbabwe a few months ago. And Honorine also, even though she's just beginning her ophthalmology practice, is very keen to help us promote and distribute this in the Francophone Africa where she's from. South Africa, we've also had a very strong reception. In fact, South Africa was where Eyeonic was launched at the SAGS, South African Glaucoma Society meeting in 2023. And you can see me here speaking to the SAGS Executive Committee, who gave a formal endorsement of Eyeonic. We now have a reseller in South Africa, and it's used in many, many optometry and ophthalmology practices, and we've sponsored many South African optometry and ophthalmology conferences. So things are going well there, and they're enjoying it. I've been very pleased to work with many of you from Ethiopia. It's been such a great experience meeting some of you and working with you. What began was a pilot study by the Oromia Health Bureau, which was carried out earlier this year, which was passed. We decided that we liked it and we wanted to use it further. And so there's a plan to roll it out to more than 100 hospitals in the district. And even the Ethiopian Health Ministry wants to use it as part of their national strategic plan involving digital health. And you can see here we've passed the local clearance at the Oromia Health Bureau, and we're going to have a presence at your Ethiopia Society of Ophthalmology conference. So I'm really pleased to be working with you all, and I really hope we continue the collaboration, and I hope that this is useful for you all. And here's some examples from the pilot that we did in Oromia. You can see that this person, the right eye is essentially normal with the pressure of 14 and a cup disc ratio of 0.3, while the left eye's got raised pressure and a cup disc ratio of 0.9. So it's this left eye with the advanced glaucoma, and you can see consequently they're missing a lot of vision, and they've got a visual index of 15%, while the right eye is relatively preserved with a visual index of 98%, and that's a normal right eye. And that's their OCT, which you can see a normal right eye and advanced loss on the left. So you can see that our test is working well in the context of the Oromia pilot. In Ghana, we've also had a lot of success, and we were a sponsor at the PAGA Congress, that's the Pan-African Glaucoma Association, back in July 24. This is Dr. Daniel LaRoche, who's the president of PAGA, performing the test, and he loved it. And here's David and some delegates from PAGA signing up to the system at our booth. And we had lots of really good meetings with key optometrists and ophthalmologists. We planned for further collaboration, and we've had ongoing presence at Ophthalmology Society and Optometry Society of Ghana. As mentioned before, we've also had a really good reception in Nigeria with more than 100 clinicians registered, and we're a major sponsor at the Nigerian Ophthalmological Society. And as I mentioned before, we have a pilot study underway, similar to the pilot that we've completed in Oromia, but this time with 12 academic centers, and that's sort of halfway through, and it's going really well. I wanted to talk for a moment about our license tests. As I mentioned before, we have a binocular driving license test, which you can see here is an example of a printout where this person is missing a spot at the bottom left, but otherwise is seeing everything else. This is currently being used in Senegal, which is a nationwide study assessing all truck drivers in Senegal to make sure that they have the correct vision to be truck drivers. But of course, it could be used similarly for driving licensing in Ethiopia. And in Australia, for instance, it's quite hard to get people into optometry or ophthalmology practices to access machines for driving assessment. Well, this of course can be done online, and we don't need the large machines, so there's a lot of potential use. Similarly, the pilot tests, which is really important. I know that there's a lot of pilots in Ethiopia, and that airline and flight's an important part of what happens in Ethiopia. And this could be used potentially for pilot licensing. You can see here that this person has clearly passed the test, and so we'll have no problems with seeing for peripheral vision for being a pilot. We feel that there's a really strong future for using our test, and in particular what our test allows is out-of-clinic screening. And that's what's so great about our online visual field test, that it allows for the first time scalable out-of-clinic screening, whether it's at screening centers, you know, on a borrowed laptop or a tablet, either in the workplace or in pharmacies or in hospitals, or simply via an email link, sending out an email to patients who have access to email and laptops, and for them to do it. And that's a major advantage of Eyeonic over other systems, and it really for the first time allows affordable population screening for glaucoma, which up until now has not been possible. And so you can see there's a lot of interest around the world. These are a few of the largest hospitals and largest eye centers in India who are really interested. You can see right in the background here the Eyeonic technology. This is a large group of Indian eye care professionals who are really interested in getting going. And this is our team, David, myself, and Dr. Jeremy Agre from Cote d'Ivoire. We're doing the same thing there. So we have programs underway for population screening in India, Australia, UK, Cote d'Ivoire, and there's a lot of advantages all around the world. It's about managing the testing backlogs, reducing the cost of the test, reducing the carbon footprint, and the out-of-clinic testing really gives peace of mind to customers. There's some patients that do want to do more testing but can't have access to clinicians to do it, and this gives them that. So we feel there's a lot of future. The future is bright. The Eyeonic visual field test will be the major visual field test in Africa, and it's about affordability, usability, and accessibility, and millions will now have access to visual field testing. Early glaucoma detection across Africa will save sight for millions. So thank you. I'd be happy to pause now for questions, and then I've got a few cases I want to go through that will show some examples of the test.
Okay, thank you, Dr. Skalski. It was a very nice presentation and very interesting to know about the icon. So shall I start? Let me start. You know, so you said the visual field is used to detect peripheral visual defect, but still the visual field also tests the central vision as well, like the macular lesion and the others around the macula and the optic nerve head, like the 10-2, the 5-degree test. So it includes the central visual field as well. And the other is I want you just to explain is what the -2 stands for, like 24-2, 30-2, 10-2. This is my second point. And the other is about this icon. He said it's unaffordable. So, like, how do patients, can anyone get done his or her vision for free, or one has to pay?
Sure.
And the other point is, he said, for early glaucoma detection, this technology is much better than the conventional one in detection of early glaucoma defect. This is one of my point I have. And the other point is,
I think I might have lost Dr. Abeba. David, or anyone is... Oh, yeah. Sorry, Dr. Abeba, I think I missed your final point.
my final point was, can anyone get print out of his or her visual field? For example, can my patient come to my clinic with a printout of his or her visual field using this icon technology?
Thank you. I'll try to answer all of those questions, and I'll leave the question about the cost up to David to answer. But let me see if I can answer all of them now. Let me just pull up my talk again. So this is a good, this might help. I'll talk through this case, which I think will answer. So this is someone who, this is a real patient, 47-year-old man. He comes for a glasses check because he's presbyopic. And you see him, and you notice a disc hemorrhage. I think everyone can see that over there, a disc hemorrhage. So what do we do next? Well, I think we want to measure his pressure. We want to find out if he's got a family history of glaucoma, and we want to do the visual field test. So the reason I show this is, one of your questions was, does this pick up early glaucoma? And I think it does. You can see here, this is a very early defect superiorly, which matches this early inferior. You can see the optic nerve is pretty healthy, but just starting to get some inferior disc disease. So I think this test is good for early detection. The next question you asked is about the -2. What does the -2 mean? And the answer means, the -2 means that when we test, we're not testing straight at the center. We're testing a little bit offset. So for instance, this is the 24-2. The first spot is 3 degrees above and 3 degrees to the right of center. The next spot is 9 degrees above. So each of these has 6 degrees between them. So we've got 3 degrees, 9 degrees, 6 degrees, and 21 degrees. But the very closest spot is not right at the center. It's offset. And that's what the -2 means. So the same for the 30-2 and the 10-2. We're not testing right at the center because that's where the star is. We're just testing a little bit offset. So that explains what the -2 means. You asked about printout from results, and let me show you the next case which might explain that. So this is a 43-year-old woman who's come for a routine check, and what you can see is there's a little bit of disc asymmetry. You can see that the cup here is bigger than the cup on this side. It's subtle, but it's there. The cup disc ratio on this side is around 0.6, and on the left side it's about 0.5. Everything looks pretty stable. The pressure's normal, the pachymetry's normal. So we did a visual field test, and you can see that it's completely normal on both sides. And so therefore, this is just asymmetric cupping or physiological cupping. This is not glaucoma. But what I wanted to show you is that there's this button here, print this page. And when you click this button, it's very easy to then print the page either as a PDF, which you save on your computer, or you can actually print it out on paper, depending on if you use paper notes. So I hope that answers those questions. And then the next question I'll leave to David to talk about costs and access.
Yes, please. Thank you, Simon. That was a very good presentation. And thank you to the OSC for the opportunity and even the work that we began before we got to this place. Simon, I think there are some questions on the chat. So as I answer the course, then you can go through and then later you can come back. So we have two packages. The first one is we have a limited usage, and then we have unlimited usage. So with the limited usage, we are charging 38 USD per 50 tests per month. This is a special price for OSC, 38 USD per 50 tests per month. That is a limited test. And then we are charging as low as 52 USD for unlimited tests per month. So 38 USD per 50 tests per month. That is maximum test that you can do per month. And then we have 52 USD unlimited per month. And then when we come to accessibility, we have a clinician account and then we have practice accounts. So with the clinician account, that is where the prices that I've mentioned is catered for clinician accounts. Now we have a practice account. A practice account is an account that is used by more than 2 people in the hospital. And it's unlimited. The accessibility is unlimited. And then the number of machines that can be used is unlimited. And we are charging 2,100 USD per year. I repeat, with the practice is an account that more than 2 users can be on. So as far as you are more than 2, you can use it for unlimited cases, unlimited machines, and unlimited accessibility. And this comes at $2,100. If you calculate this, it means if you are using more than 2 accounts, let's say 4, 5, 6, up to whatever account, we are only charging you for only 2 accounts. So that is how it works when it comes to pricing. If you have multiple or chains of clinics, we can come to a deal and we can also support you. If you have further questions concerning the course, please do ask. Thank you.
Thank you, David. Now that David's mentioned it, I see there's a few questions on the chat, and so I might just go through that if that's okay. So the first, Dr. Merriam said, amazing, thank you very much. Then there's Dr. Tewodros asked, can the visual impairment percentage calculated using Eyeonic be used as part of calculating visual impairment for medical legal cases? And the answer is yes. It's a simple yes. And I'll show you later soon some cases where we've used the driving test in some licensing cases as well. And then from Dr. Moulousset, thank you very much for this great presentation. How is the applicability of this online visual field test in very advanced cases of glaucoma? So what I will do to help answer that, I'll keep going with my presentation and show you some more cases. because the next few cases are advanced. So this is a case, this is one of my patients, a 64-year-old man who presented to me with the pressure of 20 in the right and 26 on the left. And his right visual field was normal, and you can see his right optic nerve is normal, while the left has got glaucomatous change. And you can see here he's actually got quite advanced disease, 62% visual index, with defects superiorly and inferiorly. So that's picked up the advanced disease, advanced left glaucoma, and we treated him with latanoprost drops, and initially he did well, his pressure reduced to 11. But you can see here that over time his visual field has worsened, and it turns out he wasn't using his drops. And what's interesting is that these were done in clinic, and this was done in clinic, but this was done at home. So we were not just monitoring him in clinic, but we were monitoring him at home and realizing that his visual field had gotten worse. And it turns out it's because he wasn't using his drops. So we did SLT laser and we reduced his left pressure from 19 to 15. And I hope now that he won't get any worse, but we still need to monitor him closely. And this is the same patient, but on the machines. And you can see there's a very similar trend going on with him. He's had a lot of visual field tests done because he's been part of my research, but there's the same process going on. He's getting worse, picked up by our test and also the standard machine. Here's another case. This is the case I showed you before of this person from Ethiopia with the advanced glaucoma loss on the left. So I think that answers the question. And this person's got high pressure, has got PXF glaucoma, significant loss of visual field, but a good visual acuity. So she really needs a trabeculectomy soon, I would say. This is the same person. And what you can see is both the 24-2 and the 10-2 agree with each other, where the central bit is just a complete loss. And this is another case, also from our pilot in Oromia, with someone that has no light perception on the right, and the left has got advanced glaucoma with a pressure of 7, having had a trabeculectomy and visual acuity of 6/18. And you can see that they've lost a lot of peripheral vision, but they still have some central. And when we blew that up, when we magnified that from the 24-2 to the 10-2, that you could see there was a lot of agreement between the two. This is someone also with advanced loss. This is from the machines back in 2019, so from 5 years ago, and I've been looking after him for a while. I've done trabeculectomies on both eyes. One day a few months ago, he felt his vision had gotten worse, so he came to the emergency department on a Saturday on the weekend, and the doctors in the emergency department said, "Oh my goodness, he feels his vision's gotten worse. We need to do a CT scan of his head." And so they called me because he said, "Call Simon, he's my doctor." And what I said to them was, "Well, slow down. You don't need to do a CT scan. That's, there's a lot in that. Why don't you just get him to do a visual field test now?" And they said, "Well, we can't access the big machines." And I said, "No, you don't need that. Just go online." And I showed them how to do my test. It was quite easy for them to do in the emergency department. And you can see these were his tests. This is in May this year, so a few months ago. And you can see that they're very similar. That's the right eye, that's the left eye. Very similar to what his tests were like 5 years ago. So we could tell that based on these tests that he hasn't gotten any worse. He just, thought that he might have gotten worse, and that there's no obvious progression, and there's certainly no need for a CT scan of the head. So I think it's a good example of how this technology saved the person getting a CT scan of the head. Here's another example of someone with quite advanced glaucoma, and you can see both the optic nerve OCT and the visual field shows bilateral changes. And he asks me, is he okay to drive? And this is where we did our online driving test. And because he was part of our research, we also did the machine-based estimate, which is what is done by the visual field machines. And you can see an example of just how much agreement there is. Like you can see the estimate goes out a little bit further, but these are spots that you don't actually need for licensing. So what's important for licensing is what's in the box. And you can see he's missing at the top left and missing a large part of the top right quadrant. So it doesn't matter what test you did, he did not meet the license criteria. And I think, the last few cases, a 53-year-old lady with a routine checkup, but she was noticed to have high pressures, pressure of 25 and 24. Discs looks okay, maybe slightly large, cup disc ratio. So what do? Well, we did a visual field, and thankfully that was normal as well. So we can really use visual field testing a lot to help us in these cases where we're trying to figure out whether they need treatment. She has ocular hypertension. You don't have to treat, but you can treat at pressures of 25, 24 if there are other risk factors. And as a final case, as we talked before, this is someone with early glaucoma. You can see that they're missing a little bit in the inferior disc rim, which is causing this superior loss. Pressure of 24 on the right, 19 on the left. He had SLT, which brought his pressure down to 16 and 15 with this superior nasal defect. And you can see that over time, there's always a bit of fluctuation every time you repeat the test, but there hasn't been much change, even though they were done close together, and there was no significant change. So even though there were a few dots showing that potential progression, there was not enough to show significant change. So I hope that answered the questions. And just lastly, as I said before, it's easy to access the Eyeonic test, www.eyeonic.com for a free trial. It's economical model. You can test your patients in clinic. You can allocate tests for your patients to complete remotely. And please follow us on LinkedIn. So thank you. There was a few more questions that I'll go through, and please keep the questions coming as you think of them. So the next was from Jonas. Question 1. For those of us who already have the equipment in our clinic, what would be the advantage of going to Eyeonic perimetry? Well, that's a good question. I think there is quite a bit of advantage because not every patient is happy to perform the machines or can perform the machines. And sometimes the machines break down and they slow down the clinic. So having the extra system at relatively low cost is a really good way to help ensure that your practice runs smoothly. You can also get your patients to perform the test at home if they have access to computer and internet, and that can also speed up your clinic. And finally, all the machines have a limited life. They will all eventually break down. And so starting on the Eyeonic system is a very economical way of transitioning away from the machines, because as it's software, it doesn't break down. It just goes with the computer. And then the second question is, can you save the Eyeonic visual field result on your computer, or do you need to save in the cloud? Well, I think I already answered that. So yes, the data is in the cloud, but it's very easy for you to print the results and store them as a PDF on your computer, or it's very simple for you to access the results through your login onto the system. Then there's one from Dr. Almaz. Do you recommend visual field test for population screening to detect glaucoma, since it is said visual field defect is seen with at least 50% of nerve fiber layer loss? Look, that's a good point, and that is one of the weaknesses of visual field testing that we can't get around, that it doesn't pick up the earliest stages of glaucoma, although our test, as I showed before, will pick up early glaucoma, but there'll always be some people that have optic nerve damage, but not visual field defect yet. All I can say is that now that we can do online testing, we've got this really important test that we can roll out easily. It's better than nothing. And, it's not practical to perform OCTs on everyone because they're a big, bulky, expensive machine, and we just can't physically get that to every single person. While every single person does have access to a computer and the internet. So I think we need to consider the benefits, but understand that the screening will not pick up every case, but it will pick up the advanced cases. So I think that's important to consider. Then from Dr. Mulusu, how is the clinical data stored? From ethical point of view, is it cloud-based? The answer is yes, it's cloud-based, but everything is very secure. So as I said before, we've worked very carefully with Microsoft, and we've made sure that we've got all the correct cybersecurity protocols in place. We take cybersecurity very seriously. It's a very important focus of our company. And everywhere we go, such as in Ethiopia, we apply for local regulatory clearance. And as I showed you before, we've already achieved that, to make sure that we achieve the appropriate governance and ethical approval in every country. Being cloud stored, the data is very tightly secure, and in that way it is ethical. And the other thing that's ethical about it is that the patients are in control of their own data. It's not locked on a machine, so if a patient moves from one clinic to another, they still have access to their data, and they can also share their data with other clinicians if they need to see a different clinician.
Thank you, Doctor. I don't see, more question in the chat box, but still we have, I think there is one more question. There is one more question in the chat. Is there? There is one more question.
The question from Dr. Nahom, is there unlimited or a lifetime payment package? I think I'll let David answer that. David, please go ahead and please unmute.
Thank you, Simon. Yes, please. We have unlimited package, but with the lifetime payment, I think you want to talk about buying the app. That one is unavailable, but we have unlimited package. If you want to do a deal for 5 years, 10 years, we are available, and we can have that deal done. I hope this answers your questions. Thank you.
Okay, thank you. So I have 2 more questions, and the first is for early glaucoma case detection, would you advocate 10-2 for glaucoma patients with the icon? And the second is how about the learning curve? With the conventional, the first test usually, unless it is similar with the second test, we consider as learning curve. There are many factors that affect the first visual field test. So is it this new technology, does it improve or is it similar with the other conventional visual field machines regarding the learning curve?
Thank you. So to answer the first question, you're correct in identifying that the 10-2, some studies have shown that it picks up earlier disease than the 24-2, because some of the earliest glaucoma damage occurs in the central macular branch, and so some studies find that. However, I would recommend 24-2 for screening, because if you do the 10-2, you might miss out on more peripheral defects for that simple reason. So that's why I think, as I said before, I would recommend using the 24-2 initially, and then if you suspect central defects based on that, or if you're doing something like plaquenil toxicity screening, that's when you use the 10-2. But in most situations, I'd recommend 24-2. The second question you asked about the learning curve. I would say that the learning curve of the Eyeonic is much easier than the conventional machines. And I agree with you that on the conventional machines, particularly the first one, you can pretty much ignore because that's just the learning. However, people seem to pick up the Eyeonic system a lot more quickly. And maybe what I might do is I might log into this. I'll just share my screen again, and I'm going to log into the system just to show you. It's really quite easy. You just type in eyeonic.com and you're there. And I'm going to log in. This is my account as a clinician. And you can see I've got plenty of patients here that have done tests. This is an example of someone that you can see her left eye, she's got a little bit of disease. And when we repeated it, same sort of thing. And in her right eye, she's got much worse disease, and so she's someone with relatively advanced glaucoma, and I've done trabeculectomies on both of her eyes. But what I wanted to also show you is just how easy it is to do the test. And this is the patient. This is actually me as a patient, and these are all my tests. And what I'm going to do is I'm going to click this button here so that I can do the test. And you can see how simple it is to view. I mean, it says we test one eye at a time, so close the other one. And if you use glasses for reading, put them on. It tells you to darken the room and to avoid lights shining directly on the screen. It tells you where to sit. This number is different in every computer. And it tells you to alter your seat or your screen height or tilt the screen so that you're comfortable. We'll test my left eye. Here, this pops up telling me that I need to increase the brightness to at least 75%. And that's something manually done by me pressing the keys on the computer. And here are the test instructions. So close your right eye, focus on the gold star, press space when you see this target, sit at 55 centimeters, press return to pause or press delete to enter. So I'm going to do the 24-2. But you can see it's all pretty straightforward and easy to do. And that's why we did it this way. So I'm just closing my right eye.
Your test is about to begin. Please close your right eye and look at the star at all times. Press space or click the mouse when the target appears. Press space or click the mouse to begin.
And there are different language options available as well. But you can see just how easy it is to do it. And as you can see, it's trying to find my blind spot. Pretty soon I won't be able to see these targets because they're in my blind spot. And away we go, we're doing the test. And I'm just clicking space. I'm looking at the gold star and clicking space every time a target comes on. And if I want to pause, I press return or enter. And if I want to abort, I press delete. So I hope that answers the question about the learning curve, because it really is quite straightforward. We have been doing it so that people are doing it under supervision in clinic by an orthoptist, but really it's probably not so necessary.
Thank you, Simon. I wanted to add that there is a question there which had already been answered on the chat. Yes, we have a 1 month free trial, and therefore I will urge each of you to register and then try for the 30 days. Thank you.
Okay, so we have some more minutes. I have another question as well. You know, one of the advantage of this technology is means it doesn't need technician to assist or the performance of the visual field. But you know, considering most of the glaucoma patients are elderly patients, the illiteracy rate is not low in Africa, and the different language that we have, you know, everywhere. How would you consider this these situations with this technology?
Well, I would ask the team that were involved in Oromia how they found, but in the other parts of Africa where we've been using it, despite the literacy issues, it has been relatively well adopted and well used. If people can't read, then that's when it's good to have an orthoptist supervising them. But in general, as I said, it comes in different language options, and particularly in Francophone Africa, they've been using the French version of the application, and it's also in Portuguese. And so in those situations, it has been able to be used.
Okay, so we are about to finish.
Great. Well, I just want to thank everyone.
Okay, so I don't see any new question in the chat box. Yeah. So I want to thank you, Dr. Skalski, and all the participants. It was really interesting, and it's exciting to know about this new technology. And I hope it will be helpful for Africa and for our country and for our people. So I would like to say thank you just for this nice presentation and introducing to us this new technology. And thank you all the participants. If there is no question, I didn't see any. So what I saw is just thank you in the chat box. So it's now time to close.
Yes, I wanted to plead if we could get screenshots. If as many as you can open the camera, then we quickly get a screenshot. I will appreciate.
So we have
As many.
59 participants right now.
As many as we can, then we take a screenshot. Please, could you open up your videos as many as we can? Then we take a screenshot. Simon, are you ready?
Yeah, everyone smile.
Let's give them about 30 seconds. More people are open. I think you can go ahead, Simon.
Okay. Okay, everyone. And if you have any other questions, please be in touch with myself or David. We look forward to working with you and working with you. It's a team effort to get this. It's not not every step is so easy, but we're here to help. We're here to support, and thank you so much.
And then we wanted also to announce that we'll join you at your upcoming OSC meeting.
Correct.
Thank you.
Okay, thank you, everyone.
Okay.
Thank you.
Okay. Thank you. Bye.
Bye.
Bye.